Hello, everyone, and thank you for joining us today. My name is Deanna Andel, and I will serve as your moderator for today's session. We're honored to be presenting to you a session titled COVID-19 and the Impact on Ostomy Care through the lens of WOC nurses across the country. So I think we can all agree that the past year has been a long journey filled with challenges, unexpected insights, and solutions. The ability of WOC nurses to adapt and continue to provide excellent care for patients during the global pandemic is unprecedented. Join us in this discussion about the lessons learned and how Moldable Technology has made an impact on patients and nurses in a changing healthcare environment. Now, it's my pleasure and honor to introduce our esteemed panel of speakers. Lindia Isaac is a board-certified wound ostomy nurse at Memorial Sloan Kettering Cancer Center in New York City. She has 30 years of oncological experience in an acute care setting. She's worked as a unit-based WOC nurse on the colorectal, hepatobiliary, and gastric mixed tumor service for the past 20 years. The scope of her practice involves patient education, nurse consultant, and she serves as resource for the care of all patients across the continuum of care. Her area of expertise includes the management of complex surgical wounds, enterocutaneous fistulas, and ostomies. Lindia is committed to improving patient symptoms and functional challenges to enhance their quality of life. She has pioneered new use of technology at the bedside to create a productive learning experience for new ostomates. Nora Salmon has been the WOC Specialist Manager at Mount Sinai Morningside Hospital for the past 3 years. She received her BSN at Cleveland State University in 1999 and studied wound ostomy and continence at Rupert Turnbull School of Enterostomal Therapy at Cleveland Clinic in 2006. She received her MSN in Leadership and Management from Benedictine University in 2015. Nora worked at the Cleveland Clinic for 11 years and New York Presbyterian Cornell for 6 years. Nora was inspired to become a nurse and WOC nurse as a result of witnessing her mother's love of the profession and WOC nurse specialty. After being nominated by a former pediatric patient, she was named the Honored Hero of the Crohn's Colitis Foundation in 2018. Nora collaborated on a pediatric ostomy book called Jake Gets a Stoma with the parents of a patient she cared for due to limited availability of pediatric educational content. So Jill Garacki joins us from Banner Home Healthcare and Hospice, where she has served patients since 2017. She is a patient-centric, dedicated, registered nurse serving the community of the greater Phoenix area since 2011 in both the acute and post-acute care settings. She was trained in wound and ostomy nursing at St. Joseph's Hospital and Medical Center and Barrows Neurological Institute. She was awarded the Hero Nurse of the Year from the Arizona Association for Home Care in 2020. For over 6 years, she has specialized in compassionate, innovative wound and ostomy care for patients, as well as comprehensive educational experiences for clinicians and staff. Amy Kremis is a certified wound, ostomy, and continence nurse at Marshfield Medical Center in Wisconsin. She has been an RN since 2013 and a wound, ostomy, and continence nurse for 4 years. Amy's background in nursing includes med-surg nursing, palliative care nursing, and wound and ostomy specialized nursing. Amy also has 7 years experience as a certified medical assistant and surgical assistant in vascular surgery, general surgery, wound healing, and maxillofacial surgery. She has pioneered new use of technology at the bedside to create a productive learning experience for new ostomates. Kathy Knetter has been the wound ostomy nurse practitioner for Marshfield Clinic Health System, Marshfield Medical Center, for 14 years. In her practice at this rural tertiary care referral facility in Wisconsin, she has expertise in caring for inpatients with a wide variety of wounds, ostomies, fistulas, and complex skin breakdown issues across the entire lifespan. Panel members, thank you for your dedication to the specialty practice of WOC nursing. We look forward to sharing your insights and experiences over the next hour. So now let's get started with the session. Please remember to submit questions through the Questions tab on the left side. After the session concludes, we'll have a live Q&A period with the group. Lindia, the mic is all yours.
Good evening, everyone. Thank you for your time, and thank you for giving us the opportunity to share our experience during this historic pandemic. This evening, what I'm going to discuss, I'm going to talk about the clinical, the impact of COVID-19 on our clinical practice across the country. I'm going to review some basic ostomy stoma assessment. I'm going to review some stoma complication with ostomy management care strategies, and I'm going to talk about the benefit of using moldable technology and its impact on ostomy management. So how did COVID-19 impact us in the United States? Well, we saw over 33 million new cases. Unfortunately, over 600,000 people have died and 27 million have recovered. How did COVID-19 impact us in the clinical practice? In my institution, we did see fewer patients, and because we were seeing fewer patients, so we did utilize a lot more telemedicine to see some of the patients. At the height of the pandemic, some of the outpatient WC nurses, because we saw less patients, so some of the outpatient WC nurses had to be deployed in the inpatient setting and in the COVID clinic. I'm going to say kudos to all my colleagues that had to work in patients because it's a totally different workflow. For the inpatient, the challenge we had a lot of patients that, a lot of home care services that had that didn't provide services to some of the geographic area. We were sending their patients home. And we also had some patients that did not want to have anyone coming to their home. So as inpatient nurses, we had to be very careful and very meticulous how we give information when we were sending patients home. Luckily, we had implemented a few protocol when we had our ERS patients. So we revamped all our education material. We also created new videos. And while the patient, during the in the height of the pandemic, a lot of the organizations, we were so lucky because a lot of the organization did donate a lot of iPads to every COVID patients. So we used those iPads to actually get the family's participation. And we also use these patients' smart device to videotape all the education. So the hospital, because a lot of the patients were very anxious, so the hospital created some weekly exercise and wellness classes. The patients had very positive feedback, and it actually reduced their anxiety level and stress level. Because some of the nurses also had to be redeployed because they didn't have enough patients in the clinic. So they created a COVID-19 cohort management program where when they were sending these patients home, they'll actually give them a pulse ox so they can monitor any deviation. And then the nurses will actually contact them if there's any change in their health status. And these patients were able to get help a lot sooner rather than later. Unfortunately, because we needed a lot of the beds, so they deferred a lot of elective surgeries. So we only performed procedures that were emergent or patients with cancers that couldn't wait. So as a result, it impacted screening, and some of the treatment were also impacted. For example, if your chemotherapy was every 2 weeks, they actually changed these chemotherapy to every 3 weeks. For example, if you had to get radiation 5 days a week, they actually changed these treatments to every other day. So the reason they did all these changes, this is to prevent the patients from getting in unnecessary exposure to the virus. So we know that these non-evidence-based strategies that they implemented, they were actually not just to MSK, but it also relevant in the other parts of the world. Unfortunately, with these modification and delays in treatment, we don't know what will happen to these patients in the future. So I'm going to go to my panel colleagues and ask them what changes have you seen in your practice throughout COVID-19. So I'm going to start with Nora.
Thank you, Linda. Thank you so much. Yes, one of the changes in our practice that we had at Morningside during the pandemic was trying to quickly institute a telehealth, which makes me regretful we didn't have this in place prior, because it's very hard to change into a policy in the midst of a crisis. So we quickly tried to adapt and did so the best we could, trying to help patients, especially from home. To your point, they weren't allowing a lot of patients to come into the hospital for typical things they may normally have. So we tried to work quickly, tried to get patient supplies, because even though they weren't with us, we could still manage to get them samples and such. And so trying to keep in touch with them during the crisis in order to see how things were working, while managing also our patients' inpatients. But thankfully, we were able to manage, at least from my end, most of those in a really decent way that were limiting the need for them to come into the ER.
So I'm going to go to Jill because she works in a home care.
Yes, and thank you guys for having me, and thank you, and hello to all of my home health buddies out there. I appreciate you guys being there. So with us, we had that increased pressure to reduce those readmissions for our patients. So it was really important that we did really good education. So we kind of went through and standardized our education, made sure everybody got the same information, no matter what day we saw them, they got that same information every single time. So that was really important for us. And then the other thing was, again, like everybody else has said, we leveraged our technology, and we did telehealth visits. We did visits when our nurses were in the homes and they were having issues with their ostomies. Then we would come and FaceTime with them to make sure that we were getting around to everyone, because as everyone had, we had a lot of nurses go out sick, and so we kind of had to cover our bases. And a lot of our nurses also got redeployed. So it was kind of nice that we could get all throughout all of the states. We are both in Arizona and Colorado, so it was nice to be able to go all the way around to make sure everybody was taken care of.
All right, so I'm going to go to Kathy right now.
Hi. So right before the pandemic hit, we were doing some work with our telemedicine department, and we were trying to get set up with telemedicine visits for our patients in the home setting for ostomy care as well. Because we're in rural Wisconsin, we actually serve the upper 2/3 of the state of Wisconsin. So we have a lot of patients that come from several hours away for care here, and can't necessarily come in for appointments. And when the pandemic hit, those resources needed to be reallocated for telehealth for basically the entire system. And but now that things are slowing down with the pandemic, we're able to focus those resources back with the ostomy patients population and get going with our plans for telehealth visits for them. But throughout the pandemic, we would utilize some of the same things that have already been suggested. Patients with smartphones, we would FaceTime with them, or we would have patients email us pictures, send us pictures, do telephone calls, try and keep patients out of the hospital because they didn't want to be here either. They didn't want that exposure either.
Amy, would you like to add anything?
Yeah, I guess really it was just adapting to whatever the patient had for service, because also rural Wisconsin doesn't have a lot of internet service as well. So a lot of it was still done old school or the telephone. You tried to do the best you can, but we have been able to expand with like family members going there and having to be able to FaceTime. So really just adapting to whatever the patients had available in the rural setting.
Wow, that was quite a challenge. And I also forgot to add that some of my colleagues also utilize telehealth in their practice as well. So let's go over some statistics. In 2017, it is estimated there's over 1 million people that are living with colorectal cancer. In 2020, we saw at least 140,000 new cases of colorectal cancer. Of that, over 104,000 of these cases had colon cancer. Half of them were men and half of them were women. And 43,000 of these new cases were rectal cancer. We do know that there are more men with rectal cancer than women. And we also saw over 53,000 people died with colorectal cancer. And the survival rate for the 5-year survival rate is about 64%. Colorectal cancer, we do know that it mainly affects older adults. However, there has been a rise in incidence of younger adults between the ages of 30 to 39. Colorectal cancer is the 4th most diagnosed cancer among these young adults in the US. The survival rate for colorectal cancer when it's picked up early is about 90%. So as a result, the screening for colorectal is now age 45. So during the pandemic, a lot of the patients were afraid to see their doctors, and there was mandatory deferral for any procedures or surgeries. So these patients were at home watching television, and one of the most popular advertising that we saw was for Cologuard, which is a fecal test that picks up on DNA mutation for colorectal cancer. However, this test does not pick up on precancerous cancer, and we do know that the survival rate for colorectal cancer at the early stage is 90%. So with this Cologuard, there's a lot of positive. They do have some positive, false positive, and some false negative. So if you do have a false positive, you do have to have a diagnostic colonoscopy. And just remember, your screening test is usually free by your insurance. Now that you have to have a diagnostic test, now you will have to pay co-payment. So we do know that the gold standard for all kind of colorectal cancer and precancerous lesion is a colonoscopy. And colonoscopy is the only acceptable test if you have iron deficiency, you have any bleeding, any change in your bowel habits, if you have ulcerative colitis or Crohn's disease. So some of the treatment that they do for colorectal cancer is laparotomy. We do open surgery and minimally invasive procedures. So if you have a more advanced disease, so they do, depending on the stage of your cancer, they actually do radiation and chemo. And just of note, like the chemotherapy, some of the side effects one of the side effects is peripheral neuropathy. So as wound ostomy nurses, we do have to keep that in mind, because when we're selecting a product, so if you have really bad peripheral neuropathy, it will definitely impact the product that you're going to pick for your patient. And we also have targeted therapy, which blocks the growth and spread of cancer cell while limited damage to healthy tissues. Targeted therapy is used more for advanced cancer, when you have cancer in other parts of your body. So one of the most common targeted therapy that they use at the institution is called Avastin. Unfortunately, they do have a lot of perforated bowels, and with these surgeries, when they have to have these surgeries, I'm telling you, the surgeons are not quite pleased, because the wound healing and the stomas typically don't look very good. And the other treatment that they offer for advanced colorectal cancer's immunotherapy, which is designed to boost the body's natural defense to fight cancer. So at my institution, we do ostomy surgeries that result in a temporary or permanent diversion. They're created to treat colorectal cancer, bladder cancer, ovarian cancer, obstructive tumors, Crohn's disease, or ulcerative colitis. So these colorectal surgery, they do affect the patient's body image and function. Not only that these procedures affects the patient's body function, it also, these patients have a lot of anxiety related to the cancer because they also have additional treatment besides having the ostomy. So they do have a lot on their plate. So we do, as wound ostomy nurses, we do take all these factors into considerations. So some of the most common procedures that they perform at my institution, we do LER with an ostomy or without an ostomy. And we also do abdominal perineal resection with a permanent ostomy. So lately, because some of these patients have delayed on their care and the diagnostic testing, I do see a lot more APR, and we also do total pelvic exam. At my institution, the colorectal is the fastest growing department in the second fastest growing department at the institution. And we do see over 6,000, they do perform over 6,000 procedures a year. So I'm going to go to my panel and ask them what sort of procedures have you seen in your practice. So I'm going to start with Nora.
Thanks, Linda. Yes, we at Morningside, I would say a fair amount would probably be your APRs and your LARs. We don't get a lot of pelvic exents, but occasionally we do. And yes, it's very important that I stress to these doctors that we mark them to help give them a better quality of life. But more commonly, I would say it's the reversible ileostomies we see, be it from an LAR or, might be an emergent surgeries we might see. But yeah, most commonly, those are the types of surgeries we see.
Mm-hmm. And Jill, what do you see in the outpatient?
It's about the same as Nora is seeing, but again, I agree. As we're coming out of that pandemic, we're seeing more of those drastic surgeries. The APRs, the TPEs are the ones that are really that we're seeing more in a higher number.
Mm-hmm. And Amy,
I would have to agree. LER is probably the most common, but since the pandemic, I think our APR rates have increased, or colostomies related to perforations just due to delayed care at our facility.
And I think even prior to the pandemic, we saw a shift from, we were seeing several years ago, we were seeing a fair number of procedures related to Crohn's and colitis. And now in the past couple of years, a lot of more of our procedures are related to perforated diverticulum or cancer related diagnosis. And we've seen a shift from seeing more ileostomy patients from Crohn's and colitis to now seeing more colostomies from cancer.
Wow. Well, thank you. So what happened to these cancer patients during the pandemic? So a lot of, like my colleagues just mentioned, so some of the cancer patients went undiagnosed because they had to postpone their screening. So a lot of the cancer hospitals and clinics suspended the biopsy and chemotherapy. Screening for cancer dropped by 94%. And so since we saw fewer screening, it led to a decline in new diagnosis. According to the National Cancer Institute, because of all these changes in management, so they predict in excess of 10,000 deaths over the next decade from breast cancer and colorectal cancer. And they also predict the rate to be even higher among Blacks and Latinas. So why do we do pre-op ostomy teaching? So this is the time that the patients, we determine the patient's ability to perform self-care. This is the time we get to know the patient and allow the patient to discuss their concern regarding various things, body image, sexuality. And sometimes we have to be careful because not all patients are ready for all that information. So we have to tailor the education based on the patient's mental capacity. This is also the time that we also review what they expect the stoma to be, what kind of pouching system, the options that's available, and we go over some basic ostomy care, etc. So we do know that it has been established that the patients that receive pre-op counseling, they actually do better with their ostomy and self-care versus patients that had not had any pre-op counseling. So having pre-op counseling and a stomocyte marking by a WOC nurse actually reduce complication rate. It also peristomal skin complications. It prevents pouching problem. Long-term, it improves their long-term outcome and physical adjustment. So at my institution, most of the patients are seen by a WOC nurse in the outpatient facilities. And occasionally they are marked by the surgeon, colorectal surgeon, or the urology surgeons. So after surgery, we typically, this is just a review for some of you, this is more of like for new WC nurses. So we look at the stoma, we look at the size and shape. Does the stoma have enough blood supply? For example, sometimes the surgeon may have a little bit of a hard time to get to get enough blood supply to the skin level. So sometimes you see that the tissues, the stoma is working, but the tissues over the stoma is quite dark. So just remind the patients, because the tissues, when it's dead like that, it does have a profound odor. So you just remind them it's perfectly okay. So we look at the stoma protrusion. Okay, make sure, is it at skin level or above skin level? We make sure we look at where the lumen is. Is it in the center, or it's on the side? Is the stoma working? We also look at the tone of the belly. Is the belly soft? We also look at the mucocutaneous junction. So is it intact? We look to make sure, is there any bleeding present? We look at the peristomal skin. Does it look like the other part of the body? So we know typically that all stomas are a little swollen, and we do remind our patients to remeasure the stoma for the first 6 to 8 weeks, so they are properly fitted, so it prevents any peristomal issues. So as a WC nurses, when I use a belt immediately after surgery, because I typically see them the next day after surgery. So if I do use a belt, sometimes when patients have an ileus, they actually get the belly usually gets bigger. So when you use a belt, I usually let the staff nurses know to just make sure to check, so these patients don't develop any pressure injury as a result of the belt. So again, this is a review for some new WC nurses. So sometimes you're going to see the word loop stoma or diverting ostomy. So we know the proximal limb is where you're draining whatever you're eating, and the distal limb is draining whatever leftover stool. And an in-stoma is a permanent ostomy. And sometimes you see the word double barrel or an ostomy with a mucus fistula. It's usually done when you had an emergency, you haven't had a bowel movement, you haven't had a bowel prep. Again, after surgery, we typically see stents. So just make sure we're not using a one piece, because the surgeons like to flush these stents. And we also remind our patients that these stents typically stay for 7 to 10 days, depending on the surgeon's preference. So for any rod, in my department, if they use any rod, they typically leave them for 4 to 5 days. And if the rod stays a little longer, I usually let the LIP know, so to make sure that this patient is followed up a little sooner rather than later. And for any new post-op patients with I like to use a ring, because as the stoma is changing, it does give me a little bit more protection immediately post-op. So some of the factors we take into consideration when we're selecting a pouching system. I look at the type and consistency of the stool. I look at the size of stoma and its construction. I look at the belly contour, and does the patient have any scar? What is the degree of protrusion? Is it at skin level or is it flush? So some of the characteristics the patient characteristic that I also take into consideration is, what is the patient manual dexterity? So does the patient have neuropathy? Can they use a two-piece system? Can they see? Okay, and their level of activity. Is this patient a bedbound patient? Is the patient using a wheelchair? So that way it guides me on selecting the type of pouching system. Does this patient have enough financial support resources to actually purchase their products? We know that most of the product manufacturers, they have an indigent program. So I also take into consideration the patient's preference. So some patients do like a one-piece and some patients like a two-piece. I do try to accommodate them, but I also provide the pros and cons. And sometimes it may not be feasible to wear what the patient wants. But as long as the patient knows why you're selecting it, they're usually pretty receptive. So how do we select the wafer? We usually select the wafer based on the consistency of the stool. So anything liquid, we use a duroadhesive, which is more durable. And we do recommend that they change the equipment every 3 to 4 days. However, so if you have a poorly constructed stoma, sometimes it may not be possible to have the change every 3 to 4 days. So perhaps a wear time for this patient with a poorly constructed stoma, maybe every 24 hours, and that's perfectly acceptable. Just remember, these cancer patients cannot go back because you have a poorly constructed stoma. They usually have to wait because you want the anastomosis to heal before they have that ostomy reversed. So what I usually do, I usually let my colleague in the outpatient, I give them the heads up, and I also make sure that the home care nurse is aware so they don't need to spend their time in contacting the team. And of course, if you have a colostomy, you can wear a standard wear. And we do recommend, the 4 to 5 days is a recommendation, but not everybody's wear time will be the same. So how do we choose the right pouching system? So first, so we look at to use a one-piece system, so we typically use a one-piece system when your stoma is protruding or your stoma is flush, but the lumen is actually in the center. And if you have a barrel belly or if your belly's firm, so a one-piece system is actually fine. So for a convex wafer, a one-piece or two-piece system, so we use that if you have a flabby or jelly abdomen, if you have a flush stoma and the lumen is at the skin level, you have scar or folds, etc. So we use a convex wafer. So for an ideal stoma, we can use a flat system, a one-piece or two-piece, whatever works for you. If you have a protruding stoma, you have a hernia or prolapse stoma. Sometimes with a hernia, if you need convexity, I still use the convexity. So ConvaTec has a moldable skin barrier that's a mold to fit skin barrier with a smart adhesive. What is that? So it actually provides a perfect fit for the patient. So that way they don't have to redo it again. It's very easy. It also protects the patient from leakage, and it reduces the amount of time of application. The moldable technology has a good memory, so it suits all kinds of shapes of stomas. If you have a perfectly rounded stoma, you use it. If you have an irregular shaped stoma, it works well because it has a nice memory in the system, so that way it goes back to wherever you put it and it stays there, and you can use it for oval shaped stomas. So it's easy, you just roll it back, and it has a nice memory system within the pouching system. So the ConvaTec Moldable Technology has a unique solution. So it has 3 layers. There's a leak lock. The first layer is a leak lock. So it provides a snug turtleneck effect to maximize leakage control, and it also hugs the stoma and prevents any undermining. The second layer, it has a patented rebound memory technology. So what it does, it moves as the stoma moves. And as you can see, when it forms that turtleneck, it also provides a protective layer. So if there's any mucus, it actually absorbs the moisture. And then the second picture, you see that moisture around it. It's perfectly correct. So with that, I'm going to share an example how I've been using moldable technology for the last 16 years in my practice. So during the pandemic, we had a patient who had a pelvic exam. So on the day of discharge, so it was on 6/9. So my colleague actually changed all the equipment. We use a ring, like I said, and both the stomas were fitted with the moldable technology. So unfortunately, this patient came back 3 weeks later. That was on July 1st of last year. So when she came back, surprisingly, the 6/9 that we wrote on the pouching system was still there. And I was so shocked when we took the equipment off, there was no skin damage. And unfortunately, I deleted this picture because this would have been a great example. So now I'm going to go to my panel members and ask them, how often do you use moldable technology in your practice? And what is the primary reason for using moldable technology?
Well, Linda, I'm guessing you want me to go. It's Nora.
Yes.
So we had at my former hospitals that I worked at, we used it far more often. It was part of the PAR. At the one I just came from at Morningside, we didn't have it on PAR, but it would always be an option definitely for outpatient. I used to choose it primarily for patients who are arthritic, who have difficulty, to your point. You have the neuropathy patients more often with your cancer patients, as you've identified, but also patients who just aren't adept with scissors. People would always say art is not my thing. And so I say, well, this is an option for you. And they loved it. I use it for pediatric patients as well, for safety, because using scissors they might damage themselves. So those were my primary population that I chose it for and found very successfully, works for them very well. So those are my choices.
And Jill?
We used it mostly, we use it all the time, but during the pandemic, we used it a lot for our patients that kind of had that shortened education time in the hospitals. So it's easy. We love it because it's easy and kind of idiot proof. And you can roll it out. And if you roll it too far, it just rolls back in, and there's no recutting. There's no throwing away any of the product. The other thing I love about it is that, again, we're using it for those patients that are having dexterity issues. Well, if the wafer is good and we can get that on there, we also need to look at the bottom and make sure the pouch is easy to open. And so this is the system that works on both ends, and that they can open that pouch up pretty well. And then the last one we did, we actually signed up people for the Me Plus program because we had ostomy, trained ostomy, certified ostomy nurses on the other end of that line to help fill in the gaps wherever we could with the pandemic going on.
Thank you. I'm going to ask Kathy what her experience has been.
Yes, so I've been using Moldable Technology for 10 to 12 years here, and we use it for probably about 85% of our patients. It's our primary pouching system that we use here. We have patients that have been using Cut to Fit technology for 20 years. They come into the hospital and we say, well, we're going to put this one on you here. This is what we have here. And we show it to them and they're like, well, hey, I like that. I want to, that seems easier and I want to switch. I think it takes the guesswork out of it for people. It also, with Cut to Fit technology, we were seeing, I think as a lot of people do, sometimes even though you teach patients to always measure the size of their stoma, we would see patients that would come in, and if their stoma was 1.5 inches when they discharged from the hospital and we saw them 3 weeks later, they'd still be cutting that stoma opening size to 1.5 inches, even though their stoma is now 1 inch. And then they have skin breakdown because of exposure to effluent. And so the Moldable Technology really does take the guesswork out for the patients. It takes the guesswork out for the staff as well. Staff will come in with brand new out of nursing school with limited amounts of experience with ostomies, and you show them the Moldable Technology and they're old pros very quickly with their appliance changes, and it's just really easy for people to use.
Thank you. Amy?
I would have to say the same thing. I find it very easy for pediatric patients to move into, especially out of like the toddler stage and really all the way through across the lifespan. Very easy guesswork wise. Like she said, everyone has said pretty much taking it out of there, and really we see a lot less skin breakdown related to it because of the ease of the use and how well it hugs next to the stoma. So very forgivable.
Yes. So also during the pandemic, what I also started doing is even though the manufacturer does not recommend that you use the technology that way, instead of molding it, I mold it back instead, and it adds a little level of convexity, and it has worked very well. So we know that during the pandemic, some of these patients were having trouble finding, like, for example, if you wanted to use a specialty product. So sometimes what I would do is add like an extra convex ring on the back to make it a deep convex equipment. So it really served a lot of purpose for patients, and there's no other product that I would say that gives me that option to do all kinds of things that I want to do. I can add, I can remove, I can use it a variety of ways. So readmission causes a big burden to a healthcare system. So according to the literature, at least 40% of patients with a new ostomy are readmitted with a high output. So what it does is it actually delays the patient's cancer treatment. For example, if they need to get the chemo, they have to wait. So we do know that there's no predictor for readmission. But what we know is a lack of education and depression actually these patients are at a higher risk of being readmitted with dehydration. So what it tells us is we really need to take our time and really educate our patients well. And we also, if somebody's depressed, make sure they follow up with the social worker. Our colleagues are pretty good in the outpatient. They actually would refer them before surgery, and they'll actually contact the inpatient social worker so they can follow these patients quite well. So like everybody does, we encourage the patient to drink. And so recently they added the institution to track this readmission. So they're actually added a recovery room tracker. So when these patients are going home, we not only give them a measurement cup so they can keep track, we also give them a log. And so they send them a set of questions that we work with the institution. So once their output get a certain level, it triggers an alert to the office practice, and then they'll contact these patients. So if they need to have them come in to be hydrated, they do. These patients, we also talk about dietary modification, and all these patients at my institution, they were seen by a dietitian, inpatient, and if they need additional help, the dietitian in the outpatient will also see them. And they need to make sure they've signed up dehydration and when they need to get some help. So approximately 50% of patients with an ostomy will have some sort of peristomal complication. And we know these complications are associated with symptoms such as pain, irritation, and odor, and it can significantly impact these patients' physical activity, leading to social isolation, anxiety, depression, and affects their quality of life. The majority of these complications are related to leakage. So we do know at least 34% of patients will have some sort of peristomal complication within the first 3 weeks after surgery. 47% will have some peristomal complication within the first 2 months after surgery. 52% will have some complication within the first year after surgery. What does that mean to us is, as WC nurses, we do have to make sure they're fitted with the proper equipment, and we make sure that we do follow up with this patient timely to prevent any peristomal skin complications. So peristomal skin complications have been estimated as high as 57% for patients with an ileostomy, 48% if you have an ileal conduit, and 35% with a colostomy. So what does that mean? We do need to make sure we pay attention to all the ostomates, but also pay attention to the patients with the ileostomy, make sure they're properly fitted before discharge. So I'm going to ask some of my colleagues in the panel, what sort of the complication do you see in your practice, and how do you manage them? I'm going to go to Nora.
Thank you. Thank you, Linda. So one of the most common is dehydration. That definitely has been a challenge, and I see that mostly with your ileostomy patients. And to your point, getting that education prior, but also monitoring and surveilling once they're discharged with items such as you said, measuring and keeping track of what they're taking in as well as what's coming out definitely helps with that. Another common one I'm seeing now in the hospital I'm presently at is prolapse, the prolapse situation, and that becomes very challenging. And what I appreciate about a product such as the Moldable, to your point, is that smart technology. So depending on the size of the prolapse, so sometimes that can really adapt well to the changing of the size of it with the girth of the stoma, and then with the pouching, with adapting to the length. But those are probably the most common ones I've been seeing most recently, especially.
Mm-hmm. So I'm going to ask Jill.
So we have had really the leaking that has caused the social anxiety that comes with that is probably our number one. We also have a few mucocutaneous separation issues. But again, to Nora's point, dehydration, we live in the desert. So it is, we are all chronically dehydrated in Phoenix. So it is really important that we push that water and make sure that they're drinking really well. That's probably our number one that sends them back to the hospital.
And Kathy?
So, the same things that everybody has already said, like the leakages are our most common complication that we would see. I think the point I wanted to make was the slide you had shown with the different percentages of complications for each stoma type. We don't see anywhere near I don't have data for us, but we don't see anywhere near that percentage of our population coming back with complications. And I think it's because we use such a high percentage of the moldable technology in our practice, and we prepare patients for discharge in ways that help prevent those complications from happening. Like with our ileostomy patients, very often we'll consistently use a ring or an e-conceal and with those patients to help bolster the seal. And if patients are between sizes on the device when they discharge, if they're between like a extra large and a large, maybe we'll keep them in the extra large, send them their starter kit from the Me Plus program with the extra large samples, and then do their supply order that they'll get in the next week or so with the larges. Sometimes if we're transitioning from like the large size to the medium size and the patient's stoma size is right about that 1.25 inches where the starter hole opening is for the large size, I like to keep patients there just a little bit longer, because it seems like when we transition from the large to the medium, that transition sometimes is a little tight on the stoma in the medium sized appliance, and we can get some actual stoma trauma there. So just kind of timing those appliance changes out for people and anticipating what the patient's needs are going to be. Also, I wrote down, we have a new service that we've developed here in the last year with our psychology department, that they have a psychology fellow that is really interested in GI disorders and ostomies. So we're now able to offer psychological counseling to some of our patients that are poorly adapting to their surgery or to their illnesses. Sorry, I took up a lot of time.
Oh, that's okay. So do they actually see a clinical social worker, Amy, at your institution?
Not every time. So we kind of base it off of, so if we can see patients ahead of time, we try to do that preoperative education. So sometimes you can kind of gauge your patient depending on how you think they're going to adapt to it. Where we use it mostly is those urgent and emergent stomas where they don't have time to process that data. So that post-op phase is really where that psychologist, I think, comes into play, because they help them walk through that stages of grieving and acceptance piece. So usually our preoperative patients do really well. We see it more with post-op patients that don't have a choice and they wake up with it, or, it was discussed, but they didn't truly understand, or maybe it was overnight, they didn't get to meet with our team. So we really use that psychologist mostly on the post-op side. Or if we know preoperatively, we can get them on board ahead of time as well.
I have to say it's quite difficult when it's an emergent ostomy. They have a lot of issue with anxiety, fear. It does take a lot of time managing these patients in the hospital, and even when they leave the hospital. Those are the patients that actually do not do very well with their ostomy.
Right. Yeah. Correct.
They have to grieve for the loss of their self-image as they knew it, pretty much.
Yes. And I also wanted to add a point with the mucocutaneous separation. In my practice, actually, I use moldable convex wafer immediately after surgery. And it does not cause mucocutaneous separation. If you are going to have separation, you'll still have that separation regardless. So I just wanted to add that as a note. So I'm going to highlight some of the case studies that I encounter in my practice. For the sake of time, I'm just going to review a few, okay? So this is a 59-year-old woman who had an APR. She has a history of diabetes, hypertension. She was obese. She also has MS. So after surgery, she had some difficulty walking. So because of her MS, she had a flare up. And so she wound up going to a rehab facility. And unfortunately, 2 weeks later, so when these patients are being discharged at my institution, we actually give them ample amount of supply. So for example, if you're wearing moldable convexity, we send you with a box of each. We're pretty generous, even though we know it's a waste, but that's what the institution wants the patients to go with, because we used to have a lot of foreign patients. So I think this is for the reason. So we don't want these patients to have to get new equipment. So sometimes if you are fitted with the right, you don't need to change the equipment. So this patient came back. I'm going to go back to this lady. So when she came back with a 2nd-degree burn, as you can see in the first photo. So I'm not sure what happened because they didn't use the equipment that we sent the patient with. So she kept leaking nonstop, and she came back with irritant dermatitis because she kept leaking. So what I did is I'm a cruster. So I use my crusting technique, and then I like to use a barrier when your skin is badly damaged, and I use a ring, and I actually use the medium moldable with a belt. And the patient's skin recovered after a week. The next patient was a patient who had an LER with the loop ostomy, so she left. So 2 months later, she came back. She came back with a bad contact dermatitis. Actually, this picture is not the actual picture, but it's the picture when I saw the patient, because the nurses had already switched the equipment that the patient was using from home. What I usually do is ask the team for steroid spray to get the skin to clear up sooner than later. So I use a little powder because it does burn the patient. So when you use the steroid spray, so I use that. And then I like to use a barrier. And then she was fitted, as you can see, her belly is a little soft. So I use a moldable wafer with a belt. And this is the last picture, is what the skin looks like after a week. So with a complex abdomen. So this is a gentleman who had an emergent ostomy. As you can see, they were having trouble to bring enough of the stoma to the skin level. So they did put a rod. And so we use a one-piece system at first, and it wasn't successful. So what I wound up doing that worked for him was using a large Ekin ring, and we covered the, so sometimes when you have a ring, if I can put like a barrier underneath that, I actually do. And then I use an additional Ekin over the rod. And then he was fitted with a large a moldable wafer as well, and he did fine with that. So the last person is a young woman who was 48 years old. She had stage 3 rectal cancer. She has a history of ulcerative colitis. She had a loop ileostomy for a bowel obstruction post-chemo. So she really had these awful lesions, which was diagnosed to be pyoderma. And so she did have a derm consult to make sure we rule out other issues. So she was medicated. So how she was treated, we used a steroid spray, and she was also treated for her pyoderma as well. She was giving IV steroid as well, and all her medication that she needed for ulcerative colitis. So we use hydrofiber, and I also use a hydrocolloid, and I actually use a moldable because her belly was a little soft. So I use a moldable wafer with a belt, and we change it every 3 days. And over a couple of months, maybe a month, those lesions disappear, and she was fine. In summary, so we know COVID-19 has had a huge impact on cancer screening and treatment, and we do not know the potential future implication of this deviation of care. So choosing the right pouching system at the beginning is crucial because it does save on nursing time, and it also improves patients' quality of life. So ConvaTec Moldable Technology Sink Barrier, we know, has a smart adhesive that's uniquely molded to the stoma, and it creates a perfect fit. So the moldable technology has worked well for me pre-pandemic. It worked well for me during the pandemic, and it continued to work very well. Thank you, everyone.
Thank you, everyone. What a fantastic discussion that we've had with all of you. We actually have quite a few questions, so I'm going to take some time now. We've got about 15 minutes left, and get to some of these questions from our audience. Some of them are specific to one of you all, and some of them are going to be in general. So whoever wants to jump in and answer that is fine. So one of our questions is, do you have an algorithm on what ostomy appliance to use that you would be willing to share with the audience that the night and weekend staff refer to, perhaps when there is no wound ostomy continence nurse available? Anybody? Oh, Lindy, I think you might be on.
I don't
There
have
you are.
a specific algorithm, so I use those criteria, and then I actually make sure I educate the nurses. I work as a unit-based wound ostomy nurses, so these nurses are getting education constantly from me. Any new nurses has to spend a day with me. And every 6 months, they get a re-education as well. So I use it based on what the stoma looks like. So they know if it's a flush stoma. Those are the equipment that we use. We use a convex system. I use the ConvaTec moldable, so I use that quite a bit. If the belly is quite distended, they can't have the hard, so I use a lighter convexity. And it's a rare occasion that I use a flat system. So I don't use a flat system immediately after surgery. So I either use a very shallow convexity or the medium moldable. I hope this answers, helps the person that had the question for me.
Can I chime in too? You know, we use some of the QR codes that are very popular now, I think, too, to help the nurses have easy access to the resources per the companies. So it could take them directly to the sites to see, you know, what is available as far as application of products and, you know, any suggestions of how to, you know, mold products and all of that. So it makes it very easy when you have those QR codes that can be, you know, on the units for them and available in an easy way for those resources to be accessed.
Thanks. Anybody else?
Most of our units at the hospital are stocked with pretty much the standard, both convex and flat wafers, and our nursing staff is also well educated, so we don't have too many questions for overnight or on weekends. We do have one unit that is our med surge based unit, so the charge nurses, and we have wound ostomy champions at our facility, so we have 2 from every unit, or we keep expanding as the year goes on. But they will go to the ER and help out. They'll help on another unit if there is a complex ostomy that a traditional staff nurse maybe doesn't see. So we'll send nurses from a different unit to help out. So that's how our system kind of works as well.
And if it's a patient that we're involved with, we'll usually leave a couple changes of what we're using right in the room with the patient, so that the nurses that are coming on the nights or on weekends know exactly what we're using.
And if there's anything complex, we will actually write out instructions and it'll be pinned in the patient's room if it's a specific way we want something done.
And if it's really complex, we take pictures.
And I'll just echo what Lindia said in that, and with our clinicians, we if they have distended bellies, we're going to put them in a flat. If they're leaking, we're going to automatically put them into that soft convex until somebody can see them over the week. You know, if it's over the weekend, we'll find someone to see them on Monday to make sure that we've got the right fit. But really, if you just look at the habitus of the belly, if it's real distended, we can stay with the flat. But otherwise, for the most part, we're putting most people in convex these days.
So Jill, stay on your mic. This question is for you specifically. As a home health WOC nurse, do you consult only, or do you follow each patient until they're graduated from your service?
I wish I could follow every patient. I really do, but I cover Tucson and Payson and half of the Phoenix, and then my cohort Mandy Odegaard does the Colorado, both of the Colorado pods, and then she takes the west side of the valley. So we are seeing lots and lots and lots of people. So we like to be on standby. We like to be that our nurses can call us anytime, and we can FaceTime with that patient. But unfortunately, I wish that would be lovely if we had more WOC nurses in the home health arena. It would really be helpful. But unfortunately, we just can't get everywhere.
Thank you. So now I have another question, and this one is, does the WOC nurse in your cancer center, this is for you, Lindia, an outpatient clinic, are they able to bill when they see the ostomy patients via telehealth video during the pandemic? How about pre and post-op visits?
Unfortunately, they're not able to bill in New York. You have to be a nurse practitioner. I'm not sure there's any billing. No, I don't think so. I believe you have to be an LIP, a nurse practitioner, for you to actually bill. So I will have to verify that, but I know I'm not sure it's done. They are being billed.
Can I? Yeah. Because, that's one of the challenges we have here in New York. You're right, Linda. And, our CNOs are trying very hard to even get the WOCNs to have that access being underneath a nurse practitioner. So, one of the challenges we've seen is that all the expert services we provide, but yet the limitations in being able to bill. So right now our CNOs are working on advocating for that to change. So if that's any help to that person who asked that, that is something that, again, your executives might be able to actually advocate for the service, even if you yourself are not a nurse practitioner, but you may have access to a doctor or a nurse practitioner to help with that.
That's great.
Good discussion, and it feels like a much bigger discussion on a national level, right? So then here's another question, and this is really open up to whoever would like to respond, but how did you support the patient during COVID when they were post-op and probably not coming back in for a follow-up?
Well, what we did was we would be available by phone, maybe follow up with them in a week or 10 days to find out how they're doing. We set a very high amount of our patient population up with home health to do continuing education, because we did shorten their stays during COVID. So maybe we would have kept them 7 to 10 days. We had a lot of ours out in 5 to 7 days. So we only maybe got 1 or 2 rounds of education with them. So we really were dependent on our home health system that were going into the house, patients that would allow it, and then following up with them at a week or 10 days if we thought somebody maybe would have problems, and make it very transparent for them to call us at any time, leave a message, we will follow back up with them. So it was really just being very good communicators with our patients.
And I think anticipating the supply needs and things like that too, because, some things were becoming shortages. So then, sending them home with more than you usually would, or things like that became common as well.
So actually, at my institution, I believe our outpatient wound nurse will actually follow up by telehealth, and if they couldn't help the patient by telehealth, they'll actually have those patients come in and help them that way.
Great, thank you. So this is a newer question, and you kind of touched on this already, Lindia, but because it popped up, I want to make sure we cover it again. How long do you wait after a new surgery before you place them in convexity? And actually, that's open to anybody, but Lindia, if you want to kick us off.
Well, I actually, when I see them, if I see them, I typically see a new ostomy patient the second day, the first day post-op. And if you need convexity, you get it. So I don't wait. And I work with a high-risk population. Some of these patients had chemo prior, and they've had high-dose steroid therapy. I don't see any issue. If your wound is going to open, if the stoma is going to separate, it doesn't, the convexity, because the medium moldable is not all rigid convexity, it's a soft convexity. So it does not cause any damage at the mucocutaneous junction.
Yeah, I agree. I think the needs are the most important. It's more of, and again, to your point, Lindia, the soft convexity is often a good choice because of the concern of maybe that hard convexity may cause some injury. So that's what's nice, again, too, about the moldables, having that option to have that softer convexity. When you need convexity, you just need it, and you really can't, wait to be secure about that. You got to just jump in and do what they need.
Yeah, and I think it really does change the social anxiety. If we can stop those leaks from happening and we can stop that peristomal skin from breaking down, it just changes their whole experience. So whenever we can do that, we always try to put them in soft convexity unless they're having a problem.
I would agree as well here. We will put them in convexity right out of the OR if need be.
Great, and I know we're coming up on time, but we might be able to squeeze in a couple of more questions. I think this is an important one as well, open to anybody, but how would you support a patient who runs out of ostomy supplies post-hospitalization in their home?
Can I take that one real quick? So there is a wonderful, wonderful ostomate who is, I think she's like in her 20-some year of being an ostomate. Her name is Christine Kim. She actually has a company called Kindred Box, which actually works with various institutions to try to get supplies that are free that she will ship out to them through a donated service. So please, I encourage everybody to look her up. She is fabulous, and I encourage you to take advantage of her system if you can.
And
so
we
here
have
at our
several.
facility.
Oh, sorry. Go ahead, Amy.
Go ahead. No, go ahead. We just float them supplies if they need them. So if I have patients that have reversals, they will donate supplies back. So I keep a huge shelf in my storage area that is stuff that I can donate out for free. If it becomes close to donations or getting close to manufacturers, then it goes to mission trips. So if I can donate it back out versus going into the landfill, we resupply out from that stock. And there's quite a bit from reversals because they get a lot of product.
So what I see the outpatient wound ostomy nurse at my institution do, they'll actually contact the product manufacturers directly, and they're very good at shipping the overnight, ship them some equipment. So.
And on the outpatient side, we see we have quite a few in charities in our community, but the UOAA is a really great resource for us to get them the supplies that they need.
All right. Well, unfortunately, we are at time. I want to thank all of you for just a fantastic job. Thank you for sharing your journey with all of us. It's truly an honor having you as colleagues out there. To all of our audience members who attended, thank you for your time this afternoon, this evening. all of your great questions. I'm sorry we weren't able to get to all of them, but we'll do our best with follow-up after the conference. Don't forget to do your surveys and enjoy the rest of the conference. Thank you, everybody.
Thank you.
Thank you.
all.
Thank you.